So, this case, we discussed a lot about the cochlear implant yesterday. This case is a little different in the sense, for the sake of discussion. Cochlear malformations are not uncommon, we all know. And most of the malformations are at the membranous level or cellular level, which go unnoticed even by best of the imaging. What we see on the imaging are very few malformations.
Yes, sir. True.
So, what we can see, only those cases we can discuss.
Yes, sir.
So, malformation, to understand the malformation in brief, cochlea start developing, the cochlea and the vestibule or the labyrinth start developing in the 3rd week of embryo. In the 4th week is otocyst. In the 5th week it matures into, a complete cochlea and vestibule as a cavity. आ रहा बुलाना है उनको, पेशेंट लेके आया ना, पेशेंट लेके आया, लेके ला. So, in the 6th week, the cochlea differentiates into cochlea and vestibule are two separate organs.
Yes, sir.
With their internal architecture. Afterwards, in the 7th week, the internal architecture is complete. And 8th week, it like an adult cochlea. This is how the normal development of the cochlea is. Cochlea after the 8th week goes under maturation, the bony and other maturation, to become of adult size, shape and everything by the 5th week of embryo. Our
Yes,
cochlea at this age is same what it was in the 25th week of embryo.
Okay, sir.
So that 3rd to 8th week is the critical time for cochlear vestibular maturation. Suppose your development of the cochlea is arrested in the 3rd to 4th week. When the otocyst doesn't form, there is no cochlea, no vestibule, no intra-auditory meatus, and that is known as Michel's deformity, we all know.
Yes, sir. The
And-
most severe.
Yeah, so there is nothing where we can implant, and the only option to rehabilitate with whatever available results is the brainstem implant. In the 4th week afterwards, it develops into a common cavity. The cochlea from the otocyst to a bigger common cavity. 3rd week is otocyst, then a bigger common cavity. If the further development is arrested, the final outcome is a common cavity deformity. Common
Yes,
cavity deformity means no cochlear vestibule separated, is a common cavity, and the intra-auditory meatus is directly at the medial end, and there is no internal architecture. And through the cochlea is in contact with the CSF. So that's a common cavity deformity. You can imagine the kind of deformity it is in terms of giving results or whatever. So that if the development is arrested between 4th to 5th week, the final outcome is a common cavity deformity. Then afterwards, the cochlea differentiates into vestibule. The labyrinth differentiates into cochlea and vestibule.
They both become different.
Yeah. So in the 5th week or afterwards, if the arrest happens to occur, there are two separate cavities. Cochlea separate, vestibule separate, good adult size, but no internal architecture into the cochlea. That is incomplete partition type 1. So if the development is arrested, cochlear development is arrested after 5th week, the final outcome would be a incomplete partition type 1, where there is no cochlear internal architecture and directly connected with the, no modulus, nothing, and directly connected with the intra-auditory meatus, giving a high chance of gusher, direct gusher. Common
Yes,
cavity, direct gusher, IP1, direct gusher. Got my point?
Correct. Yes, sir.
Then afterwards, the internal architecture developed, cochlea comes to its final size, vestibule comes to its final size, and during the 6th week, the variety of cochlear vestibular hypoplasias happen to occur.
Yes, sir.
In the 7th week, further, internal architecture develops. During that, if there is one deformity IP2 which happens to occur during the arrest of development at the 7th week, when the vestibule is little dilated, the cochlear development is partially, the modulus is intact, the basal tongue is intact, but the middle and apical tongue, no separation, and they become a common cavity sort of a thing, the middle and apical tongue. And there is enlarged vestibular aqueduct. After that, the vestibular aqueduct comes back to normal size. So that is incomplete partition 2, and all together with the vestibule and the entire vestibular aqueduct, enlarged vestibular aqueduct, known as Mondini's deformity.
Mold. The most commonest one.
Yeah, and this is what the case is. And afterwards, IP3, which is a different kind of, partition abnormality in the cochlea, which is also known as X-linked syndrome, wherein the outer walls of the cochlea are deficient. Only endosteum is good, the periosteum and the outer wall is deficient. And cochlea only is surrounded by endosteum. No modulus mature and direct communication with the CSF space, giving gusher. Giving a different kind of a picture of the cochlea with a normal size, but no periosteum or outer bony wall, only endosteum. So that is the periosteal or bony deformity of the cochlea, giving known as incomplete partition 3. So there are variety of deformities depending upon when the development is arrested in the embryo. Why I am telling this, so that one can easily understand what kind of deformity can happen at what period of time. I hope it is very clear.
Yes, sir.
Now, we have discussed yesterday what all to be seen on CT scan. See this. This intra-aortic meatus, to me it looks bigger. Can you see?
Yes, sir.
Kind of bulbous one around more than 6 millimeters.
Yes, sir.
So I can expect a gusher or oozer in this case. Not gusher, but maybe oozer.
Oozer, yes, sir.
This vestibular aqueduct is conspicuously enlarged in Mondini deformity. This is one deformity where the vestibular aqueduct is enlarged. Can you see the enlarged vestibular aqueduct as
Yes,
compared to a normal one? Vestibule is little dilated, not much.
Not much.
Now coming to the cochlea, see the basal tongue
Very much.
and no architecture differentiation between the middle and the apical tongue forming as a common cavity.
Yes, sir.
No difference between no partition between the middle and the apical tongue. Can you see?
Yes, sir.
So the basal tongue is there and the apical and middle tongue fuse to coalesce to form a common cavity. This is known as type 2, IP type 2, with together with the enlarged vestibular aqueduct and the little enlarged vestibule known as Mondini's deformity.
Yes, sir.
Rest of the things are same like any other cochlea, like a regular cochlea. Now this is round window. Since the basal tongue is intact, what we believe the maximum stimulable fibers for the regular, hearing are lying in the basal and the middle tongue. So if the basal tongue and the interscallar partition with the middle tongue is intact, still the maximal stimulable fibers are intact and can give good results. So
Yes, sir.
this with little bit complicacy of the oozer or the gusher, otherwise it looks like a normal implantation and a regular electrode is used because the basal tongue is intact, partition of the basal tongue is intact and The modulus is intact. See the modulus here. Modulus is intact. Not very well formed, but it is still intact. Can you see?
Yes, sir.
So this separates from a IP1 or another other massive deformity, this IP2 from.
Sir, just a question.
Yeah.
In case if the intra-acoustic meatus is dilated and our this thing is modulus is intact, still there are chances of pressure?
You don't know what is happening at the membranous level.
Okay, sir.
Sometimes everything looks normal and there is a defect at the membranous level and you get a surprise leak. Gusher.
Yes, sir.
I told you we cannot pick up the membranous defect by any radiology.
Yes, sir.
But looking at a little bulbous intra-aortic canal and little enlarged aqueduct, I can expect some sort of at least oozure.
We can see the facial also, sir, right now.
Yeah, that's a horizontal facial.
It's horizontal facial.
Yeah. Facial nerve anomalies are not so common in cochlear malformation except one or two situations like in common cavity where the facial is just superior to it, or in when there is a absent or malformed lateral semicircular canal, then it can happen. Otherwise, most of the time the facial nerve remains normal in course and position.
Little bit on the selection of cases for malformed cochlea, which can be done upon and which has to be left for.
All have to be done.
All have to be done.
Obviously, accordingly, you have to be prepared. Like common cavity, IP1, IP3,
Yes,
you have to be prepared to deal with gusher. And our proposition, in any given situation when the CSF leak is imminent and gusher, the best technique we propose is a subtotal petrojectomy to confidently seal the gusher. Got my point? To be able to seal the gusher most confidently at the cochlear level and then obliterating the entire cavity, that rules out the future possibility of a CSF leak.
Okay.
At the same time, closing the extra-aortic canal and the Eustachian tube. So that's the best way you can prevent future CSF leak and further infection if you do a subtotal petrojectomy and obliteration in situation which warrants a gusher. Common cavity, IP1, IP3, we always do a subtotal petrojectomy.
Okay, sir.
We can't take a chance to
This
do.
is just like going one step ahead.
Yes,
Okay.
because in any way after the implantation, your external middle ear are not going to participate in the hearing. And gusher can be deadly sometime if it invites meningitis, if it is not handled very, very effectively and you cannot take a chance. Once you have a technique available where you can effectively close the gusher by means of a subtotal petrojectomy obliteration, we must do it. This is the most standard technique in these situations. That's why every cochlear implant surgeon must be well versed to do a subtotal petrojectomy like I had shown in the last case. You should be able to drill away, excentrate all possible air cell tracts and drill away the Eustachian tube. Huh? क्यों? So boss, in a couple of minutes we'll be back with a microscopic picture.
Okay, sir. You are going to watch for the case, sir?
Yeah, yeah.
Okay, sir.
अजी क्या हुआ सर, कर रहे हो ना? हाँ नहीं करानी, फिर इतनी साइज होगी, कैसे इलाज होगा? क्यों क्यों डर गए? करानी नहीं है, ऐसे रखनी बीमारी। फैलाएगा एक दिन में सर को थोड़ा थोड़ा साइड हो जाए. Okay, this one. सही करो, आगे लाओ इसको, इसको आगे लाओ ना. ऑन करो, वो लाओ, टीवी इधर लाओ. हेलो. ओके, सो या yes. So rest of the steps are same like you saw yesterday. The only thing is to manage is a different implant. Yesterday I did the cochlear and today the metal one. It is metal concerto 2, is it? So I'll quickly go through the surgical steps in the beginning. See this? My insertion is a regular retro-auricular with a small superior extension. This curvilinear. Hello.
Yes, sir. Yes, sir.
Bhatia boss, I know you have been doing a lot of implants. You have at your center. I know you are doing a lot of government scheme implants also.
Yes, sir. All because of you, sir.
Arey, no, boss, you are champion.
अरे सर कोई चैंपियन नहीं है सर.
So this is a regular.
There are two. I openly say to my colleagues, there are two eras of clinic. One is जैसे BCAC होता है ना सर. One is before Dr. Satish Jain and after Satish Jain.
Oh, come on.
So yes sir, after you everybody has learned it, and I think everybody who is sitting in the hall will vouch for that only.
We are all learning from each other. Science is evolving.
So you are very
Always. See, we have reached the canal anteriorly. This incision respects all the vascularity. And see, this is now I am doing this additional undermining.
Yes sir.
This is where my processor is going to come, the implant is going to come. So I am doing this little extra undermining. And
Sir, there are many types of flaps also. And
yes.
Kindly, the next step is that only, so please explain for.
Variety of flaps one can make, inferior based, superior based, whatever. The idea behind the incision and flap making is the closure should not be a tight one. The incision line should not fall upon each other. It should respect the vascularity. See, this incision doesn't spoil any vascularity. The vascularity from below comes from the occipital artery and the posterior auricular artery, and here above the superficial temporal artery, middle temporal vessels, and all those have lot of anastomosis, and this incision doesn't spoil anything. Now, this undermining, see this incision is coming at this level. Now for the flap, my incision will be at different level. So no incision will fall upon each other where the chances of breakdown are more and can expose the implant. So this is additional security we can give by preventing incision falling upon each other. If giveaway happens to occur at one incision, that can expose the entire implant. Now, this is the lower limit, this is the mastoid tip, this is our canal here. This is the canal. So,
Yes, sir.
what our preferred technique is to make a superiorly based flap. See this. I am going bang on the bone inferiorly. This is a random flap. See inferior incision right on the mastoid cortex. See this? And as you go above, keep it more and more wider. That's a random flap. We should respect the principle of any random flap of 2:1. See now, this flap contains the muscle and the periosteum. So musculoperiosteal flap it is. And see, I am elevating the periosteum which is so tightly tethered to the bone, underlying bone. See this periosteum?
Yes, sir.
So this is a musculoperiosteal flap. See this?
Yes, sir. And it's quite wide also, sir.
Yeah. So now what happens when you close, leave it? See, no incision is falling upon each other.
Yes, sir.
And secondly, after covering this entire thing will cover the implants. So implant will be very, very safely covered, unlikely to be exposed in any remote situation.
And moreover, it will go away
Knife.
from our area of action also. It's not coming in the field also.
Yes, yes, not at all.
Yes, sir.
See, as I am going up, my flap is becoming more and more wider.
Yes, sir.
That you have to do with all the random flaps. If you are making it bigger, the base should be more and more wider, okay?
Yes, sir.
Give me the template, post-auricular template. See this? This I make sure here that this microphone should not overlie the implant.
Yes, sir. At times it can happen.
Yes. Yeah, give it. This is my mark. So my implant will be behind this, okay?
Yes, sir. Our processor will
Can
come
you
behind it.
can you put a suture? Yes. बताओ suture मारो. This is your extraordinary canal. We can harvest a piece of periosteum here to seal the final cochlea. Piece retract kar. See, this is the piece of periosteum I am harvesting, which is needed at the end of the surgery to seal the cochleostomy.
Cochleostomy. Sir, at times emissary veins come at this particular.
Yeah, you can bipolarize. You can bipolarize simply or use a bone wax,
Bone wax.
whatever.
So bone wax does not cause any secondary complications? of
Not always. Not always.
Okay. So one should avoid the bone wax kind of a
Yeah,
situation.
bipolar is the best.
Bipolar is best.
No. Now see what I am doing. When you elevate the such flaps, the tissue retracts,
Yes, sir.
and it may fall short
Yes.
for the final closure.
Yes, sir.
So what I am doing, उठा के रखिए, घुस जाएंगे नहीं अंदर. This is additional undermining of the tissues.
Will give us better tension-free.
Yeah. That should be done prior. And later on can invite bleeding,
Yes, sir. On the later part then.
So you can do like this. लगा ना? ये पकड़ यहाँ से. This is more and more undermining. See this?
Yes, sir.
It is always a good practice to do it before. Utha, utha, Naresh, marwai. So, should be done. This is very, very important to give a tension-free closure at the end of the surgery. See this?
Anteriorly also.
Little bit, not much.
Not much.
See this, but all around. You can do this undermining for a better tension-free closure.
Sir, do you tilt the table while doing, or you put any extension kind of a thing for a better visualization of middle ear?
What extension? No, no extension.
No, you simply place the head in a neutral position, sir.
Neutral position.
Absolutely no head tilting, no bed, floating table
No,
tilting.
tilted, little tilted towards opposite side.
Opposite side. That too when required, or if it is a mandatory, you do it like that.
Yeah, yeah. This is what we do generally. See now, undermining all around. And rather than using retractors, we prefer to use stay sutures. See the stay sutures superiorly, anteriorly, posteriorly, and quickly in no time we'll be drilling. Our next case is the skull base osteomyelitis. That has been operated twice earlier somewhere, and we'll do something definite today for that patient.
So that osteomyelitis is that typical diabetic immunocompromised?
Yes, yes, yes. Diabetic.
And twice what surgery has been done, sir? Radical
Mastoidectomy. And a patient has a persistent discharging ear. Painful discharging ear.
So what you will be planning to do, sir? Just little bit of the
Debridement. We'll discuss after this, definitely.
Okay.
So now, our cortical work starts immediately after this. I am going little quicker. We discussed all these things yesterday in detail.
Yes,
अरे
sir.
किधर गया वो पैडल यहाँ रखो ना नीचे बॉस इसको नीचे रखना See now, this is a crude cortical mastoidectomy for the access to reach out to the cochlea.
Yes, sir.
This approach has a beauty that you don't spoil or violate your field with a relatively, infected extra-auditory canal field.
Yes, sir. That is the
Advantage over the other techniques.
other technique. Yes.
See this mastoidectomy in no time.
Yes, sir. In no time, sir. Madam is saying half second, sir.
See this. Hope the picture is good there.
Yes, sir. Sir, even mastoid hair cells also know that Dr. Satish Jain sir is operating, so they also be aware.
I am thinning and thinning the posterior canal wall more and more.
Yes, sir.
The two landmarks I am supposed to see at this level. One is the lateral canal and second is the incus. Can you see?
Yes, sir.
That is the level of the lateral canal and that is the level of the incus. Incus is a useful criteria to follow for the posterior tympanotomy to relate the facial nerve. Facial nerve is always medial to the incus.
Yes, sir.
Now see, I am increasing the magnification.
Lateral also is a very important landmark, sir, for facial
Yeah, that is again the facial is medial to it.
medial to it. Always stay.
Now see, I am going in the depth of the canal. See the angulation.
Yes, sir.
Following, my facial nerve is medial to the level of the incus, and posterior tympanotomy is a space between the facial nerve and its branch chorda tympani.
Yes, sir.
This is to open up that space in between to reach to the retrotympanum. We consider lateral limit as chorda tympani to refer to the annulus, so that if we stay medial to the chorda, automatically the annulus is left lateral to it, and we don't enter accidentally into the extra-auditory canal. That is the whole idea behind choosing the chorda as a landmark.
Yes, sir.
Still I am using the cutting burr without any pressure. See this?
Yes, sir.
See the big size cutting burr being used without any pressure.
Yes, sir.
And I am looking for the change of colors. See, these air cells are the air cells of
Retrofacial. Around
No,
the picture.
these are facial recess air cells.
Yes, sir.
Yeah, one size smaller. Can you see? These are retrofacial air facial recess air cells
Yes,
through
sir.
which we are going to go in the retrotympanum.
Yes, sir.
So, see this? We are already towards our area.
Usually, what is usually the first structure you would like to see whenever you open the tympanotomy? Matlab in an optimal condition.
We define our superior and inferior limits. I will show. Now see medially. Can you see the change of color, the facial now? Here medially.
Yes, sir. Kindly point for everyone of us. Yes, we can see very well, sir. The whitish black. kind
Yes.
of thing. Yes, sir. We can see.
Once we see the facial now, then we change to the. Hey,
Dimension. Course
गिर
dimension.
गया, हाँ. Yeah. See, this is the facial now, change of color. Can you see very clear?
Yes, sir.
This facial now goes toward the stylomastoid foramen, and few millimeters above the stylomastoid it gives rise to the chorda tympani. See the chorda tympani there, laterally. This is the chorda. Look now. This is chorda. Can you see?
Yes.
This one, just lateral to the suction tip. Chota karo. Now, as you go deeper, your size of the suction, size of the burr keep reducing,
Keep reducing.
and the magnification keep increasing.
Yes, sir.
See now for the better demonstration. Hope the picture is good.
Perfect. Perfect, sir.
See the chorda tympani laterally, lateral to my.
Yes, sir. You are working perfectly in between both the limits.
Yes. See this? Chota ek side. See such a huge facial recess. This size of the facial recess never changes after the birth. This is the same size in our body what it was at the time of birth.
Okay. Got the point.
Leaving a thin bar of bone where the incus is inserted. Now showing the landmark inside. My superior landmark which I intend to see is the tendon of stapedius. Can you see?
Yes, sir.
This is our superior limit to look at. Okay?
Yes, sir. Yes, sir.
And our area of interest is below that. Okay?
Yes, sir. Yes, sir. 2 millimeters
So,
from the
yeah, so orient yourself, look at this tendon and stay downwards. Okay? Now focus downwards. See, I am drilling anterior to the facial now.
Yes, sir. I think at this juncture the angulation of microscope is also very important.
Yes.
In case we should be looking from lower side to upwards so that we can see the things.
Yes, the angulation is very important. No doubt. And this is the region of the round window which I am now going to focus on. This is the region of the round window with a big round window niche.
Hypotympanic.
Yeah, there is a big round window, thick round window niche. See the glimpse of the round window.
Absolutely.
And if I see from above, this round window niche is preventing the visualization.
Yes, sir.
So, in order to make it better, what you need to do is,
Drill the niche out, sir.
yes, and I will thin my facial, the bone anterior to the facial nerve more.
Yes, sir. This is for which reason, sir? Since we have already localized the round window.
Yeah, so that your angulation is perfect.
Okay, yes.
See such a huge facial recess. Now patli, bilkul.
Since, just a point, sir, since you have done a very good posterior tympanotomy, we can very well see and differentiate between hypotympanic cell and round window niche.
Yeah.
In case some surgeon would have opened a small posterior tympanotomy and he would be seeing from a narrow area,
Can be.
confused with
Yeah. And this has happened, and they can implant in the one of the canaliculus in the hypotympanum.
hypotympanotomy.
See this. I am.
Everybody should do the widest possible tympanotomy
Yeah.
for light and various other things.
Yeah. Exposure one should never compromise with. See the niche I am drilling off,
Perfect, sir. Perfect.
and true round window is being discovered. Can you see the round window now?
Yes, sir. So what will be your approach, sir? Cochleostomy or inferior insertion or?
What I want is a straight shot implant.
Yes, sir. Which always you
ओए
propagate
छोटा
the
देना
idea.
बहुत लंबा है छोटा दे so straight shot implant means the long axis
Kindly tell us the area
बहुत
from
बड़ा
which
है
you will go for cochleostomy. How do you select that, sir?
no see let me tell you don't fall into this discussion of cochleostomy round window or whatever our aim is to do a straight shot implantation in the long axis of luma of the scala tympani of basal tongue.
Yes, sir.
So we should be able to see first the long axis.
Yes, sir.
In order to see that, if you are able to do that with a round window, then you don't need to anything. If you are not able to see, you have to remove the bone inferior to the round window to make the long axis in alignment.
Yes, sir.
The area is the straight shot insertion.
Yes, sir.
See, I will show you. अरे क्या कर रहा है बहुत बड़ा है यार See the round window.
Yes, sir.
Now, if I push my implant through it directly without looking at the long axis, this implant will go first and medially hit the modulus.
Yes, sir.
And then the implant will be beyond control and keep crawling inside here and there, hitting here and there the walls of the inner walls of the cochlea, osseous spiral lamella, everywhere, and you never know where the implant is going to go.
Yes, sir.
We want implant to stay right in the scala tympani.
Yes, sir.
So we want a straight shot insertion. See this, the entire exposure of the round window. Can you see the round window very clear?
Complete round window we can see, sir.
Now what I am doing, see I am removing the bone inferior to the round window,
Yes, sir.
not medial to it.
This is the area where you are going to go for cochleostomy, sir?
Not cochleostomy, I will enlarge the round window inferiorly.
Okay.
I am not making any separate cochleostomy or anything.
Okay, sir.
Until I get a straight shot view of the scala tympani.
Yes.
And this bone is the obstacle.
Yes, sir.
Give me right angle. Patli dena is bone. Steroid rakhna. See, I am removing, opening the round window now.
Yes, sir.
See, I remove the part of the bone, but still this bone is coming in the way of straight shot. See this?
Yes, sir.
We are not able to see the full view of the scala tympani.
Yes, sir.
Now how-
More of little bit of anterior.
Yeah.
rather than-
Now how can we get the full view now? See this. In a minute's time,
You have till the superior overhang of the things.
in
And
fe-
this is the cresta, sir.
yeah, this is called crista. And now see the whole length of the scala tympani. Can you see?
Yes, sir.
Let me show you steroid.
You can see the complete tunnel going inside.
Yeah. So the implantation will be a cakewalk, straight insertion. That's it.
Without hitting the modulus. of the
Nowhere
head.
right. See this?
It will. Yes, sir. It will not touch the neural structures. It will go straight away.
Yeah. See now the pressure is little higher. I would say oozer.
Ooh, yes, yes.
See this. It refills very fast. See this.
Yes, sir.
See the pressure. It is coming and refilling a little faster than usual. Can you see?
Yes, sir.
This is called oozer. So this is expected in this scenario to have a oozer. And I can flush the lumen, the cochlea from inside with the steroid. See the full lumen? Complete straight lumen.
Yes, sir.
This is the inferior tunnel in the cochlea, the scala media and scala vestibuli are above. And this is the inferior tunnel, so my implant will go right into the tunnel. See the tunnel?
Perfect, sir.
It is not going to hit here or there. Give me the gel form. Now we'll cover it for a while. Can you induce the next case, skull base osteomyelitis? Ask them. See this? This soaked in steroid, okay? We'll leave for 10-15 minutes and cover this to prevent bone dust from going inside, okay? And now give me the template. वो देना प्लास्टिक वाला. I hope this part was very clear. Hello.
Yes, sir. Yes, sir. We are with you.
I hope this part was very clear.
Perfect, sir. Perfect. Perfect.
No, no.
Okay.
ज़्यादा दूर मत लगे.
Medal. Medal.
This is medal.
Medal.
Here, here. Give me the.
वो तो बंद.
So now next 5-10 minutes will be लगातार लगा के देखना. Will be to spend in making this well and the gutter for the cable and then we'll fix up the implant in next 10 minutes. We'll be through.
Yes, sir.
So it was just an oozer and we'll seal the cochleostomy, okay? The next case is being induced and that is a case of वो ले लिया स्कल बेस इंड्यूस करो so this is a mechanical work. This is we are making the well for the implant for the fixation. There are various techniques of fixation and still no और बड़ा थोड़ा मेरे को दे दो पूरा प्लस बड़ा इससे बड़ा yes. Yes, dear.
Sir, the template that you have used, metallic template for marking,
Yeah.
earlier that was coming with metal.
Earlier than?
This template is different than earlier one.
Earlier means?
मेटल में पहले जो आता था उसमें नॉच नहीं दिखता था.
हाँ, that was a side tube. Metal has variety. That you, yeah. The earlier implant would have a side exit of the, the electrode channel, and this is a exit in the middle.
That's what, sir. Earlier it was inside. Sir.
Yes.
Thank you, sir.
So every implant comes along with a template. So accordingly, you have to, make the well for that.
Yes. That nucleus cochlear also, that exit is from.
Everyone has a different size, shape,
Yes.
profile is different. This is very good profile, thin one. And metal is also versatile in terms of making variety of electrodes and implants.
So which model we are going to use in this, sir?
Concerto 2, today we have is Concerto 2. Yesterday we did a nucleus implant, cochlear one.
Yes.
Okay.
And sir, do you prefer to make a island in the
Yes. Yeah, that is good so that it should not over project the surface bone. If it over projects the bone surface, it can make constant pressure on the skin and can give rise to problem. Yes. Can invite infection. Yes.
Yes.
So it should remain in flush with the surface bone. So it is always good to make a island and keep it pushed with that. Though this implant is a very favorable profile. It is very thin,
Yes.
not very thick. This patient is a 2-year-old child.
Yes, sir.
The youngest we have implanted is 8 months old.
Oh, that's great, sir.
That too bilateral, same stage.
In single stage, sir.
Single stage bilateral. Nowadays we are doing most of the pediatric patients bilateral, same stage.
So in that 8-month-old child, sir, what was the dressing of post-operative dressing, sir?
Dressing is bilateral dressing.
So, comparatively had that weight on the head, sir.
Yeah.
The dressing.
Yeah, that's a very, the dressing is same whether to do unilateral or bilateral. Bilateral, you have to be more careful about the chorda, you have to be more careful about the symmetry, more careful about the infection, equipments,
Yes.
So, but it is best for the patient, ideal. So, if possible, bilateral same stage, in the prelingual patients, ideal. If not possible because of the money constraints or whatever reason, medical condition, the especially
In the government funded implant, only unilateral, sir.
yeah, that we do not do any government scheme for that matter.
Yes.
So if you are doing sequential, then it should be as early as possible, within 6 months to 1 year, to get a binaural good summation. If the second implant duration, the interval is too long, then this bilateral summation can be affected.
Yes.
See, this is the well, and we'll fix with the side holes. Or fixation is something we are always biased towards doing this kind of a fixation than periosteal one, though that is also equally good and make the implant fixed. But we have been doing this and getting good results for beginning, and this is more, I would say, secure in our opinion. Implant should not be mobilized, otherwise it's a disaster.
Yes, sir.
See this?
Very nicely fitting, sir.
So the choice of implant in this particular case, it was patient's choice or it was some specification for which you preferred
See,
Marie?
we do all implants, so we always leave upon the patient
Okay.
with all the choices, no personal biasness or anything. See, this is,
Actually, madam's question is that in cases of malformed cochlea,
yes, sometimes,
different kind of
yes,
situations.
yes. Like for example, if it is a cochlear hypoplasia, then we use a smaller electrode. If it is a common cavity or something we want implanted in the periphery, we want a full banded electrode, not half banded ones. So it depends upon the anomaly. In ossification, sometimes we need a dual electrode implant, one electrode in the basal ton, one in middle ton, sometimes triple one, wherever, whatever maximum possible we can stimulate from wherever. So it depends upon the situation. In otosclerosis and in the facial dehiscence cases, we want a perimodular one, away from the facial nerve. So to prevent facial stimulation, yes. So depending upon the situation, you have to choose the electrode as well. You are right. Stopper concept. There is a question about the electrodes with the stopper. Stopper earlier, one electrode was introduced with the stopper. That has been gone to disrepute because of the chances of giving infections. So nobody is using nowadays.
Sir, any experience? Kindly share your experience with the otosclerosis for implants. Sir.
Yes. So those are the implants.
Or done upon with stapedectomy.
Okay, decision making. Let me tell you, profound deafness with otosclerosis. The decision making between the implant and stapes surgery is driven by CT scan.
Okay, sir.
So, if it is a profound deafness with otosclerosis, yet cochlear changes, demineralization of the cochlea is not very severe.
Yes, sir.
Still, the first choice is the stapedectomy followed by hearing aid. Most of the time it works, even in the profound cases. Stapedectomy followed by hearing aid.
Yes, sir.
If it doesn't work, or there are lots of cochlear demineralization which otherwise in times to come making the implant insertion more difficult, straight away implantation, otherwise we'll lose the opportunity.
opportunity of what? Residual hearing or
Opportunity of insertion in future.
insertion? Yes.
Yeah, when the cochlea is hollowed out with lot of demineralization, then we will not be able to insert in the right lumen or won't be able to find the lumen or will be completely closed.
Sir, is that any, just a question, that is just my query, sir. Is there any situation like somebody has done the sclerotomy for otosclerosis and later on, the later part of his life, the disease was progressive and now it has gone into SNHL? Is it possible?
So first is to use the hearing aid, and like any indication for implant, any indication from youngest to oldest for any region, when the hearing aids do not work is the indication for implant. So if SNHL happens to set in, first is to try the hearing aid, the patient is not happy, not giving result, then you can think of doing an implant. That is indication as always for any region.
And does the having a piston into the middle ear changes any approach?
No, doesn't.
Doesn't.
Forget about it.
Doesn't at all. So
Okay.
having a piston in the middle ear and then we are offering a cochlear implant at a later stage. So how to deal with that kind of a situation, sir?
Now piston is of no use.
So we have to take that piston out and remove the oval.
Yes. No use. Once implant is in place, the middle and external ears are not participating anymore in the hearing.
Okay, sir.
So this is 2,0 proline for fixation, and in next 10 minutes we'll be through with this case. The last part is the easiest one, that is insertion, because we have already a straight tunnel to push in our implant.
Yes, sir.
Easiest part of the entire surgery is insertion.
Yes, sir.
See this? Implant.
Yes, sir.
Can you open the implant? So now, finally, before opening the implant, ensure about the hemostasis, wash away the bone dust. Wash देना, पानी देना, मेरे को दे हाथ में. Cut. Cautery. Manufacturers always, recommend to avoid cautery once the implant is open. Though it is not hard and fast by the literature, but still we should follow the manufacturer's recommendation. Otherwise, if anything goes wrong,
Yes, sir.
they are not going to help out. Fine? Everything set?
Yes, sir.
Loud.
Perfect, sir.
Gauri, implant. So we have here Miss Gauri from the medal for the final NRT after this. Gauge please. Then implant. Yes. Say this fixation. The most most reliable non-tooth de. Tight knee.
8 ही में नहीं
बस.
बस भाई बस
Bye. Then a non-tooth. Hmm? Okay.
Now you will slip the ligatures.
I will invert them. They should not come, this proline and should not come in contact with the skin surface, under surface of the skin, otherwise can erode and invite infection. See this?
Yes, sir.
This will invert inside and put some Sugicel to ensure that it remains in place. See this? Last part. Steroid, पतला दे दें. Forceps.
Ready.
See the opening into the cochlea. Steroid.
It is still losing out, sir.
Yeah, this is little expected.
Expected.
See the tunnel. The long axis of the tunnel. See this? See the tunnel. Entire tunnel. Can you see very clear?
Yes, sir.
So the last part is, as I said, is a cakewalk. See my electrode?
Yes, sir.
It is going flawlessly.
Perfect, sir.
It cannot go anywhere. And that's the end. That's it. Can you see? Once this electrode goes for a distance under vision, straight, see this? This coil can be coiled like this, periosteum.
Boiling always has to be done on the superior part of the mastoid.
बड़ा है. The coil, what?
Has to, sir, has to be done on the superior aspect towards the incus.
Why?
Otherwise, there are chances it's written on the books.
No. I'll tell you the reason and what I'm going to do for that.
There are chances of exclusion otherwise, something of that.
I have a solution for that. That's what I'm going to show you. See, my fixation all around with the periosteum. Can you see?
Yes, sir.
It should hold the implant on its own. Can you see this?
Perfect. Very good, sir.
Half in, half out, holding the implant. Self-holding the implant.
Yes, sir. Assembly is absolutely taut.
Yes. Give me the gel foam. Now, coming to your question where the coil should come out. Let me tell you and why. Why we keep this long coil in the mastoid? Yes, so mastoid is supposed to grow in size. And accordingly the cable will take the dimension. Okay? Now, we know the middle ear at the time of birth is of same size as it was in the adults. Got my point?
Yes, sir.
So we fix the implant at one end outside
Yes, sir.
here. Now, the part of the middle ear in this process where the cable is coming out is where? From the cochlear entry to the edge of this posterior tympanoid is part of middle ear.
Yes, sir.
And this is not going to change. That is of adult dimension. Got my point?
Yes, sir.
What all is going to change is the mastoid size. Okay? So this is my next fixation at the level here inferiorly.
This is bone dust.
Bone dust, and this will make a complete bone here. This will be another fixation at the level of the medial edge. The outer fixation is the level of the lateral edge on the cortex, because neither the outer is going to move on nor the medial from the round window to edge of the posterior tympanoid grow.
Yes, sir.
So this is double fixation both ends. The middle part can grow, and for which we have extra coil.
So this is just bone dust, nothing you have added in this?
No, just bone dust.
Okay.
Simple. And that's what about the implant is. Now the Gauri can do the NRT quickly. Connected? Connected or not? So this will check the impedance. All good? So impedance is all good. Impedance shows the integrity of the electrodes,
Yes, sir.
and the neural response telemetry will show the responses of the electrodes.
Sir, since this was a congenital malform, you have selected the case to demonstrate.
Yeah.
So it was best in your hand. But what all things might have gone wrong, or what you should anticipate at these stages?
A blind insertion should never be attempted.
Okay.
Always make the straight shot insertion. Your implant should go under vision for a distance, and then it will take the course of the cochlea automatically. It will not hit the walls here and there. Secondly, this NRT, what we do is gives you a sense of relief that everything is okay. It doesn't mean that it always comes, because the environment of the cochlea is changed with bone dust, blood, bubbles. All these things can affect the electrical current. So once you have a good insertion, there is no doubt about it. You don't need, your NRT cannot change your, outcome. If you have a slightest of doubt on insertion, the radiology can be game changing. That can affect the outcome. Okay?
So finally, just before you leave the OT, I just want to see how you will proceed. Just you don't suture, but just show how the flaps are coming together.
The same flap will release and suture all around. We have already done undermining all around.
And what is the position of the implant in relation to both the flaps? Only is that part
Implant will remain hidden inside the flap, underneath the flap. It won't be visible anyway. The flap will cover the implant completely.